Hi everyone, Kane Guthrie here, and I'm just here to talk to you today about aortic disasters. So, disease and emergencies that involves the aorta is what we're going to cover. So I think the learning points for the next half an hour for this talk, we'll do a quick recap on the aorta anatomy and physiology. I'm going to give you an overview of aortic emergencies, and we're going to specifically look at abdominal aortic aneurysms, so AAAs. And then we're going to finish off by looking at aortic dissections. And there's two types of aortic dissections that we're going to look at there. So when we're talking about the aorta and aortic emergencies, we know that the aorta is the largest artery in the human body. Okay, it's quite a scary part of the human body because when things go wrong, the outcomes can be quite catastrophic and devastating. The aorta originates and comes out from the left ventricle and it extends all the way down through the abdomen where it bifurcates with the common iliac arteries. So when we look at the anatomy of the aorta, we can see there that it's this big vessel that comes off from the left ventricle as your ascending aorta and then goes down into your descending thoracic aorta, which goes down through your abdomen. You can see there some renal arteries branch off it, and then it bifurcates into your left and right common iliac arteries. Also, up the top of the towards the head, you have your subclavian arteries and your carotid arteries that branch off that ascending aorta, which gives you that perfusion to your brain and limbs that way. So it is quite a challenging vessel to manage, being the largest and biggest in the body. And you can see where things can go wrong that can be quite catastrophic. When we break it down into a cross-section of the pathology of the actual aorta, it can be broke up into 3 to 4 different layers. So you have this endothelium lining, which sits closest to where all the blood runs through it. And then down there you have an intima layer. Then you have this media layer, which is the strong muscular layer. And then you have this outside coating of those layers, which is called the adventitia. And this is where we start to see things going wrong when we look at ballooning and in abdominal aortic aneurysms. It occurs in the intima and media layers. And when we look at aortic dissections, it's when we start seeing it where they get dissecting through one of these layers, which can then compromise the vessels. So the main function of the aorta is to distribute oxygenated blood to all parts of the body through systemic circulation. So it's vital for life, okay? So that's why when we're dealing with someone that's critically unwell, that's got sign of vascular compromise, we need to think, could this be aortic pathology, and address it and rectify it quickly, because this is a time-sensitive emergency, regardless of what's going on with the aorta. So I'm going to move into some case studies now. And so case number 1, this is a 66-year-old male that presents to ED by ambulance. The paramedic presents to triage and they tell you that they've got some renal colic for you. And they report that this 66-year-old male presents with sudden onset of right-sided loin pain. Okay. You're the triage nurse. You take a look at this patient and this patient doesn't look too well. They're pale, they're sweaty, they're grey. You have a look at their abdomen and you notice that there's some form of pulsatile mass there. And you think this doesn't quite look like renal colic. You've seen a lot of renal colic over your times, but this patient looks a lot worse than someone with renal colic. And you need to anchor on those things, or those cognitive hunches. Okay, when something doesn't feel right or doesn't look right, act on it, okay? So you give this patient an ATS2 and you move them through to the Resus bay. And we've got to be mindful here when paramedics or when patients give us history and that we don't start anchoring on the first impressions or the first things that we're told. And that we actually use our clinical acumen and our judgment and these cognitive hunches and dissecting all the information to think what could actually be causing this and what's likely to kill this patient, okay? And this is the cognitive bias of anchoring, okay? And this is where things can become unstuck and bad outcomes have happened to our patients. So anchoring biases where there's a tendency to perceptually lock on salient features in a patient's initial presentation too early in the diagnostic process and failing to adjust the initial impression in light of later information. Okay, and so we can also get confirmation biases in that as well. So it's always to be good of these types of heuristics and biases that can come into and make these presentations challenging, and to always think of worst case scenario. When we get this patient into Resus, we get some more history from him. We know that he's had a previous myocardial infarction that he's undergone stenting for. He's got known uncontrolled hypertension. He's a smoker and he doesn't know what medications he's on. So this is a patient with extensive cardiovascular history that we need to be worried for and start to think of worst case scenarios. So we need to get this patient onto monitoring. We need to get a 12-lead ECG. We need to get blood pressures on this patient. We need to know what his heart rate is. We need to get vascular access and to see what his acid-base balance is, and to see if he's got any signs of hyperperfusion, which would trend through with a raised lactate. You get this patient onto the monitor in Resus, and straight away you notice he's tachycardic at 118. He's slightly on the borderline for saturations at 94%, and he's very hypertensive with a blood pressure of 73 on 51. And you can see there he's got a mean arterial pressure of 58. So this is a patient that's potentially shocked with ongoing hyperperfusion, and we need to address this rapidly to see what's going on. Fortunately, one of the emergency ultrasound consultants comes over straight away, notices that this patient looks unwell, and starts with an EFAST exam, and notices when he gets to his abdomen that he's got a big dilated aorta there. So this is consistent with the abdominal aortic aneurysm, and you can notice that there's free fluid within the abdomen. So this patient's incredibly unwell and has potentially got a ruptured AAA unfolding in front of you. We quickly race this patient to the CT scan while someone's notifying the vascular surgeon that we've got a potential ruptured AAA in the department. And this confirms that you've got right-sided retroperitoneal blood. So this patient's actually ruptured his abdominal aortic aneurysm into his retroperitoneal space. So he's bleeding into the back, as you can see there on those CT pictures. So just doing a bit of a recap from this patient. So this patient has an abdominal aortic aneurysm that has ruptured. And so abdominal aortic aneurysms without rupture occur in about 2 to 4% of the population. And most of these are diagnosed incidentally or picked up on other imaging for some reasons. 90% of these involve the descending aortic aneurysm, and they're generally infrarenally, so above the renal arteries. We know that the pathophysiology is commonly caused by atherosclerosis of the aorta, so we know that this patient has uncontrolled hypertension, he's a smoker, and has cardiovascular disease, so they're risk factors for developing atherosclerosis. And when you develop atherosclerosis, that leads to degenerative changes in your elastic properties, so that intima, media, and adventitia that we see in the lining of the aorta causes that. And so this allows for the aortic to stretch, and this is what results in aneurysm formation, and that causes a weakening of the vessel, which puts them at risk for rupture. So your risk factors for having an abdominal aortic aneurysm is being aged over the age of 60, a background of hypertension, having high cholesterol, and non-peripheral vascular disease as well. When we're assessing someone or trying to work up patients for abdominal aortic aneurysms, most patients are actually asymptomatic. Okay, some may report some typical pain in their abdomen or lower back, and patients with a known AAA and pain, so worsening pain, and if they've got a known AAA, then we need to prepare that they're going to imminently rupture, and we need to get these patients to an operating theatre as soon as possible. And patients with a AAA and stable vital signs should not be reassuring, because it can catastrophically go wrong at any moment in time. You also need to be aware of atypical presentations because they are common in AAA patients. And so patients may not complain of just abdomen or loin pain, but they may actually complain of chest pain, thigh pain, pain going down into the inguinal area or into the scrotum in males. So atypical, you sometimes need to have a high index of suspicion in patients presenting with these to rule out abdominal aortic aneurysm. So the classic triad that you're going to look for within a ruptured AAA is hypertension, pain, and a pulsatile abdomen mass. So if you're thinking someone might have a AAA and they've got hypertension, pain, and you're noticing a pulsatile abdominal mass, remembering patients that have quite a lot of adipose tissue over the stomach, you most probably won't notice a pulsatile abdominal mass. But hypertension and pain, think about rapid abdominal aortic aneurysm that's potentially ruptured. Other signs that can be consistent of retroperitoneal hemorrhage, so this is where they're bleeding into the abdomen, and this can sometimes take a little while to develop. So if they've got a slow bleed or if they're bleeding into the retroperitoneal space, then these signs may develop. So you may see Cullen sign, which is around the periumbilicus, some bruising developing. Or you may notice on their loin, they get some bruising developing. That's called Gray-Turner's sign as well. The key point I want you guys to think about that with patients with a ruptured AAA can have stable vital signs secondary to rupture into the retroperitoneal space. And because this causes tamponading action, so they bleed into this space, but because the organs are compressing it and holding it there, they can hold their own for a while. Patients that bleed anteriorly and into the abdomen from a ruptured AAA is generally a catastrophic and unsalvageable event unless they rupture on the operating room table or as they arrive into the emergency department and you can get them to theatre rapidly. So what diagnostic tests do we need to think about in someone with a ruptured AAA? We're going to do bloods. The simple thing we can do is a VBG. And we're going to look for a low hemoglobin and a high lactate, so anaerobic metabolism going on. We are lucky that most emergency doctors now have ultrasound skills, so doing a focused assessment sonogram and trauma scan can actually look to see if there's actually free fluid within the abdomen, and it can also look to see if they've got a dilated aorta as well. And if you see free fluid with a dilated aorta, you need to call the surgeons as soon as possible. Generally, the surgeons, if they've still got some bit of stability, they're going to want a CT abdomen or doing contrast aortography to look to see where the bleeding is, because that can help guide them in surgery. But if they're critically unwell and unstable, they just need to go to theatre straight away to have this repaired. Your management for these patients, if they're asymptomatic and it's not ruptured, then you're going to arrange for them to be seen by a vascular surgeon for review. If they've got ruptured AAA, it's 100% mortality without surgical intervention. So you need to get these patients to a vascular or even a general surgeon that can get them to theatre and stop and clamp off that aortic rupture and that bleeding that's occurring, and suture and close where they use a mesh and graft over the aorta and contain that rupture and get the aorta back flowing as soon as possible. So from an emergency nursing point of view, at the bed, you want to ensure that you've got large bore intravenous access. So at least 2 size 18 cannulas, even bigger if better, because you may need to give these patients multiple units of blood to maintain their hemodynamics. You can give them supplemental oxygen because they are shocked, and these patients have hemorrhagic shock. You want to make sure that you get their blood type and cross-matching done as soon as possible. We're going to use the massive transfusion pack, and we're going to let theatre know that there's potentially a patient coming with a ruptured AAA so they can get prepared and ready. There's a key concept with managing these patients with a ruptured AAA, and that's called permissive hypertension. Because we're going to have to give these patients blood because they're bleeding out, but remember, the higher you drive their blood pressure up, the more they're going to bleed out that rupture. So we're generally just going to keep giving them blood to actually maintaining a systolic blood pressure around 100 or their mean arterial pressure to 60. So we just want enough to keep perfusing their brain. But if you drive that blood pressure up any further, then they will deteriorate more because they will bleed more. Your vasopressor of choice for these patients is going to be your massive transfusion pact. And if we can do that of 1 to 1 to 1 of packed red blood cells to FFP to platelets, remembering all the other things that we should be giving to patients with hypovolemic shock from blood loss, so stuff like tranexamic acid, calcium as well, remembering calcium's a good inotrope in patients that you're giving lots of blood to because of the citrate toxicity in the blood as well. So optimizing those things can make a big difference to the patient. So how did this gentleman do that came in? So we got the vascular and general surgeons were called as soon as possible, and we prepared to get this patient to theatre. On arrival to theatre, the patient goes into cardiac arrest. So our options here are we can do CPR with standard ACLS, but remember this guy's hypovolemic, so he's most probably arrested because he's got no blood pumping through his heart. We can start massive transfusion, resuscitation. The surgeons have the option of doing an urgent laparotomy and clamping his aorta. Or there's another nifty bit of equipment that's come out in the market in the last 10 years that they're using a lot in trauma, and that's called REBOA. So REBOA stands for Resuscitative Endovascular Balloon Occlusion of the Aorta, and it's indicated in ruptured AAAs, postpartum hemorrhage, or massive unstable pelvic fractures. So it's a Selinger technique that goes up in through the femoral artery, and they place this big long balloon-like catheter that goes up into the aorta, and they're going to put it up above the renal arteries, hopefully above the rupture, and then they actually inflate a balloon in there. And what that does is form an internal tamponading device to stop any further bleeding distally to where the balloon's actually been inflated. It does cause distal ischemia, so you can have a safe ischemia time above the renal arteries of about an hour or below the renal arteries of about 3 hours. But if you have it much longer than that, then you may start getting compromised limbs distally to where the balloon's inflated. But it can buy you time to get them to theatre and to actually repair the ruptured AAA. So it may get used up in theatre, and that's what was used in this case. So how did this patient do? So they successfully were able to place the REBOA through his femoral artery. Following successful placement and giving adequate massive transfusion, they were able to get return of spontaneous circulation. This allowed the vascular surgeons to graft his AAA that was ruptured. He spent 5 days in intensive care, being optimised following this, and he was discharged to rehab 12 days later, neurologically intact. So overall, a good, successful outcome. So to finish off, when we're looking at AAA, if you've got a patient that's aged over 60 with loin pain, always consider a AAA. Survival can occur in these patients if they've ruptured into the retroperitoneal space, but you still are against the clock and have to recognise and intervene as soon as possible and get these patients to theatre. REBOA is something that we may start to see more about for different conditions like ruptured AAA and bring it down into the emergency department over the next few years to actually buy us some time. And getting these patients to the operating room as soon as possible is where the patient needs to be. That's all I've got for AAA for you now. We're now going to move on to case number 2. So case number 2 is a 73-year-old male that presents complaining of severe abdominal pain. This patient, this is the history that we get from the ambulance sheet. So you can see there that on arrival, when the ambulance got there, he's sitting and talking to him. He's alert and orientated, and he has some family there on the scene. His presenting complaint is sudden onset of central abdominal pain, where on palpation, it gets worse. He has nil chest pain, but he's starting to get some pins and needles down to his left leg. He's had some nausea and diarrhea post the onset. He states that the pain is 10 out of 10 from the onset and it's radiating to his back. The ambulance officers report on their physical exam that he has a soft abdomen on palpation and they noticed nil pulsatile masses. So they started to think about aortic pathology there. But because they couldn't feel a pulsatile mass, they most should be not so worried about a AAA. They give us a history there that his onset of pain was about 8:30 and that he's normally a fit and well individual and he's on nil medication to date. He does have a history of fibrosis to the lungs and he's got no blood in his diarrhea. They report that his patient's becoming more tachycardic and BP is trending down on transfer. He's had some fluids on Danzatron, and because he's not looking too well and his BP is trending down, they upgrade to a priority 1 to bring him in as soon as possible to us. We get him into the Resus bay and this patient looks critically unwell. He's got this abdominal type chest pain. His vital signs are okay at present, but he is in 10 out of 10 pain. We get a chest x-ray there and you can notice there that he's got a widened mediastinum. And when you've got a widened mediastinum, there's a few conditions that it can cause that, but the one to worry about is, could this be an aortic dissection? So because he's looks unwell, 10 out of 10 pain with a widened mediastinum, we get him off. We get a blood gas off as soon as possible, and we also book him for a CT chest to rule out aortic dissection. So we can see there by his VBG, he's severely acidotic with a pH of 7.1. Moving down through there, we also notice that he's got a lactate of 8.5. He's got some renal impairment developing. His potassium, sodium are all within normal limits. His HB is okay at the moment at 131, but he is acidotic with high lactate, which makes us worry. And we should always worry when we start seeing these things. So he's mostly developing a metabolic. He has developed a metabolic acidosis there, and this is worrying. We get him to the CT scanner as soon as possible, and it confirms what our initial suspicions were, that this patient's got a type A aortic dissection with an intimal flap. So you can see there in that top left section, that's his aorta, and you can see there that's his ascending aorta, and you can see that big line there in the middle is the dissection flap. So this is what an aortic dissection looks like. So he's also got, when we look at that from the dissection, it's mostly going all the way down his descending aorta, because on the left side you can see there he's got this severely profound hyperperfused kidney. So this is an aortic dissection. Unfortunately, this patient was rushed to the operating room by cardiothoracic surgeons, and as they were trying to get him onto heart-lung bypass, so extracorporeal membrane oxygenation, to actually repair his aortic dissection, he suffered a cardiac arrest and was unable to be resuscitated from it and passed away. So acute aortic dissection. What do we need to know as an emergency nurse about finding these patients, resuscitating and managing someone with an aortic dissection? So the most common catastrophe of the aorta, and it's 3 times more common than actual AAA, which we've just talked about. So aortic dissection is the type of acute aortic syndrome, and it's characterized by blood entering the medial layer of the wall, and this creates a false lumen. And so when you've got this false lumen developing, you get further hyperperfusion to organs from that. There's a concept that we talk about which is acute aortic syndrome, and this refers to a spectrum of life-threatening aortic pathologies that can result in aortic dissection. And those 3 things are where they can develop these intramural hematomas in that medial layer. They can develop an atherosclerotic ulcer that can also result in dissection, and also aortic dissection, where you get that blood entering the medial layer and that creates that false lumen. There's two types of aortic dissections that we need to be aware of. So type A, which this patient has in the case, involves the ascending aorta. So this can extend distally and surgically is usually indicated for these patients. Type B aortic dissection involves the aorta beyond the left subclavian artery only. And generally we start off managing these patients medically with really good BP control to stop that stress that's occurring and help with that false lumen that's developed. But certainly type A's will need to go to theatre. Type B's is generally medical management first. So we can see here, and you can see there in the first picture, so that's a Stanford type A aortic dissection, and this involves the ascending aortic alone. In picture number 2, this is Stanford type B aortic dissection, which involves the ascending aorta and some of the descending aorta. And in Stanford type B dissection, this involves the descending aorta alone. So this is purely just the descending aorta and doesn't involve any of that ascending aortic pathology. So the pathophysiology of that, so we've talked a little bit about how atherosclerotic ulcers developing and stuff, and then you can get intramural hematomas. But following a dissection, blood flow into the media may cause extension that goes up and down. We can also get ruptured aortic dissection, which are catastrophic and generally not salvageable. We can start getting vessel branch occlusions, and remember you've got your subclavian and your carotids that run off there and also down into your renal arteries and stuff, so we can get hyperperfused kidneys. We can start getting neurological symptoms presenting. Aortic regurgitation can occur, and a common sign that we see is pericardial effusion or tamponade developing, and this is mainly with your type A aortic dissections. When we're looking for these patients, so when they're presenting at triage, some of the things that may make us think that they have an aortic dissection, quite often that in the literature we talk about chest pain that's ripping, tearing in nature, that's a sudden onset and it's maximal when it comes on, but this isn't always present. So retrosternal chest pain can generally mean anterior dissection. Patients that get interscapular pain, so pain going between their shoulder blades, can occur in the descending aorta. Severe pain, or the worst ever pain of their life, when patients present with chest pain, 90% of the time it can result in aortic dissection. Sudden onset, sharp or tearing in nature, mitigating pain, pain going down into their back. These are another things that can mean with aortic dissection. Generally with aortic dissection, the pain comes on suddenly and it's severe from the start, where we know with acute myocardial infarctions, sometimes the pain can start on slowly and then ramp up. The other thing to be aware of, because of those vessels that branch off on that, like your subclavian arteries and your carotid arteries and that we can get other end organ symptoms. So it may not all be cardiac related. So aortic dissections can present with neurological symptoms. They can present as a syncope, as a seizure. We may notice limb paresthesia, pain or weakness, flank pain, shortness of breath, and hemoptysis as well. And like we saw in this patient, he had abdominal pain, a little bit going up into his chest, but he also had pins and needles going down to his legs. And that's because he dissected all the way down that way. You may hear aortic regurgitation on auscultation. These patients are often hypertensive, and most will have a history of ischemic heart disease. But like anything, atypical presentations are also very common in aortic dissection, and they may not present with all these classic symptoms and signs. Risk factors that we need to be aware of. So there are certainly in younger patients that can present with aortic dissections, and these are generally patients with Marfan syndromes or Ehlers-Danlos type syndromes where they have collagen deficits that makes them at high risk for this. You can also have genetic predisposition, so familial aortic dissection or Turner syndrome. More in your older people, aortic wall stress can result in aortic dissection, so hypertension in 72% of patients with aortic dissection. Other cardiovascular risk factors, so smoking, high cholesterol. Patients that have had previous cardiac surgery or known structural abnormalities, so bicuspid or aortic valve issues can also be at risk. You can get it iatrogenically, so if patients that have had a recent cardiac angiogram can present as one of the complications from that angiogram as an aortic dissection. Certain infections that can cause it, so syphilis or some vascular abnormalities like arteritis, so giant cell arteritis, that can result in aortic dilatation and aneurysms developing. We also know that certainly where places where there's a lot of cocaine use, cocaine can result in chronic catecholamine-induced hypertension that can result in a spontaneous aortic dissection developing. We also know that as we age, we get reduced resistance in the aortic wall that can place you at risk as well for an aortic dissection. So when you're looking at these patients at the end of the bed, we know that aortic regurgitation is common. You also want to look for hypertension. Neurological signs, so things like limb weakness and paresthesia. Signs of cardiac failure that may be occurring, so increasing shortness of breath, peripheral edema, chest pain, those sort of things. If these patients present in shock, that's a very ominous sign, and we need to act rapidly and aggressively, or these patients can result in a catastrophic outcome. We can do bilateral BPs, and this can tell us that if there's a difference of 20 systolic between the two, may lead us down the path to actually look for aortic dissection. But we also need to be mindful about 20% of the population have greater than 20 systolic in both arms for bilateral BPs and are completely asymptomatic and don't have an aortic dissection. So it's not a great test, but certainly if there is a big deficit, then we should think about aortic dissection. Another thing to also feel is for pulse deficits between extremities. So certainly feeling for the carotid and the femoral pulses at the same time and notice a difference in intensity can also be a clue that this patient may have aortic dissection. Investigations that we can do, quite often these patients will just present with a normal ECG. If they've got inferior ST elevation, this can be because the right side of the heart is involved and they've got a right coronary artery dissection. On bloods, we'll generally notice that they'll have a mild leukocytosis, so maybe a small inflammatory marker rise. Troponin is often elevated in these patients. D-dimer is also elevated in thoracic aortic dissection. And if you've got a negative D-dimer, it's very unlikely that this patient will have an aortic dissection. Once again, with the chest x-ray, you're looking there for a wider mediastinum. And if you've got a wider mediastinum and you're unable to explain it, then you most surely need to go ahead and order a CT scan to look for aortic dissection. Other further imaging that we can do is CT scan. It's easily available for these patients. It has a really high sensitivity and specificity. And it can also assess for complications. So if we're getting ischemia to the gut or the kidneys, like in our case, it'll show that up as well. Some of the disadvantages of taking these patients to CT is you're actually taking them out of the Resus bay, but we actually take the Resus bay and the staff that we need to successfully resuscitate this patient to the CT scanner to get the imaging done. If we can't take them to the CT scanner because they're too critically unwell, we can do a TOE, which is a transesophageal echocardiographic. So this can be done at the bedside and it can detect that intimal flap that's developing. It can also tell us if they've got pericardial tamponade. It can also tell us how well their left ventricle is functioning. These patients will need to be intubated to have this, okay, because it does go down into the esophagus. It may cause hypertension because it's an uncomfortable procedure, which may make the dissection worse. It's not widely available, and generally we need a cardiologist or a cardiac anaesthetist to be able to come and do that, and special expertise is required. Other things that we can do is an MRI or aortography, but the two things that we're most likely to do in the emergency department is a CT scan or a TOE. Your management priorities for these patients are always going to be around controlling their blood pressure, because that's going to lower the stress on that intimal flap that's developing that can get worse. So the higher the blood pressure, the worse that dissection can. We need to control any bleeding, and we may need to fluid resuscitate these patients depending on how they're presenting. So we want to get wide bore IV access in these patients. We want to do invasive monitoring, so we want to insert an art line into these patients. We may need to warn the blood bank early and request the massive transfusion pack to be ready. These patients, certainly if they've got a type A aortic dissection or even a type B, we want to correct any coagulopathy because they're going to bleed more, and they may make the dissection worse if they're actually coagulopathic. Our measurements and our goals for maintaining their heart rate and their blood pressure control, we want to aim for a heart rate of about 60 to 80 and a blood pressure of about 100 to 120 systolic. We're going to use if they've got a difference in their bilateral blood pressures, we're going to use the arm that has the higher blood pressure, and that's where the art line should be inserted as well. Okay, so use the higher value, don't use the lower value. Okay, so we want to use the higher value to actually guide our therapy and treatment. And the way that we control their heart rate and their blood pressure is quite often we're going to use IV beta blocker combined with some form of vasodilator. Okay, so we'll generally for an IV beta blocker, we'll start with propranolol, esmolol, or labetalol. Okay, the most common one that we use at the moment is about, I think, propranolol or labetalol as well, that we can titrate in an IV infusion. And then if we need to use a vasodilator on top of that, then we can use stuff like GTN as well. But we want to start the beta blocker first, because that'll actually help slow down their heart rate, and because they can get reflex tachycardic from vasodilators, and that can cause further aortic wall stress and further worsen that dissection. So you're starting your beta blocker first. So your indications for surgery and taking these patients to theatre, and these for aortic dissections are generally managed by cardiothoracic surgeons. So if they've got persistent pain that we're unable to get on top of, they've got a type A aortic dissection, they've got any blanch occlusion, so to the subclavian, carotid or femoral arteries, then they need to go to theatre to actually restore that perfusion. Or in type B aortic dissections that continue to expand despite optimal medical management. Okay, these patients will need to go to theatre and have it repaired. So I think the take-home points from this aortic dissections is dissections are very difficult to detect, and we need to think outside the box with these patients, and patients may not always present with the classic sign of chest pain radiating through to their back, but they may present with some chest pain or abdominal pain with associated neurological type pathology or uncommon symptoms. So think about dissection there as well. Once we diagnose it, we need to speak to the surgeons as soon as possible. You want to control their heart rate and their blood pressure, because this prevents further aortic wall stress and prevents worsening of dissection. If they've got a type A aortic dissection, then they're going to need to go to theatre. If they go to type B aortic dissection, then we'll start them on beta blockers and vasodilators as maximal medical management first. And if they're failing that, then they may be considered for operative intervention. That's all I've got for you for this talk on aortic pathology and aortic emergencies, and I hope that you found some of it useful. Thank you very much.